Your time has started. Okay.
Yeah. Okay. Can I start?
Yeah, please. So what are the findings you are seeing in this video?
Yeah. So I can see that this is a 2-year-old boy who looks well alert, who looks well grown. Still, I would like to plot him on the charts to know where is he lying. I can see that he is in the OPD setting, first initially sitting on his parents' lap. I can see that there are few hypomelanotic and few hypomelanotic patches which are there involving his right thigh and right leg. Later, the child is standing where I think that there is a leg length discrepancy where the left leg is shorter than the right leg. There are even these, I am not very sure about the hypertrophy of the leg. So I think that there are these hypomelanotic patches which are there along the Blaschko's lines.
What is your diagnosis?
As he is a boy and he has these complaints since almost 1 month of age, which have not increased, and looking at these patches over the Blaschko's lines, my first differential would be hypomelanotics of ITO.
Okay. Okay, so this is a girl child. Suppose this is a girl child and having this issue. Okay, so do you have any other differential diagnosis?
Yes, if this is a girl child, there can be other possibility of incontinentia pigmenta, which is a X-linked dominant condition where there will be multiple stages of these rashes. So they will be along the Blaschko's lines, but they will undergo through multiple changes.
Yeah, okay, all right. So all right. So think this is a girl child and having this issue. Okay, so what is your diagnosis then finally?
So if this is a girl child, then my first differential I would keep it as incontinentia pigmenta.
Okay, so how do you manage this child further?
Uh, so basically, I would like to take the history. Since when are these skin lesions? Are they evolving into the other stages like vesicular stage or any other
Mhm.
hyperpigmented or hyperpigmented stages? Then I would like to see for the milestones. I would like to see the weight gain of this child. I would like to even see for the associations like these kids may have hypertrophy or they may have eye changes of the pigmentation or they may have even the CNS changes. Sometimes the cardiovascular system is also involved. So I would like to see for all these systemic associations.
Okay, what do you expect in eye?
There are the eye pigment, it is hypopigmented iris basically. They may have.
Okay, all right. So what examination would you like to do in that case?
So I would like to first see the general examination of this child. I would like to see the vitals. I would like to see these patches, the hyperpigmented patches. I would like to see the eye examination, formal eye examination with the slit lamp, and systemic examination, the neurological examination, the musculoskeletal examination, and cardiovascular examination.
How do you confirm the diagnosis of incontinence pigmenti?
As it is a X-linked dominant, so basically the diagnosis is clinical, supported with the genetic diagnosis.
Okay, all right. So how do you manage this child further?
This child will need a multidisciplinary team in the form of a pediatrician. This child will need a dermatologist. This child might need a neurologist for the CNS associations. This child might need a ophthalmologist if at all there are any vision issues. and this child will need a geneticist, as this is an X-linked dominant condition for the next pregnancy management, and this child will need the family will need a lot of education regarding it, support, and when this child grows, then this child may need school liaison also to avoid issues like bullying.
Okay, all right. So what is the outcome? What is the prognosis? How is the prognosis?
Um, I don't know about prognosis. I think it is guarded. About the skin problems, these are usually uh, the cosmetic problems, but associated. Sorry, I don't know about the prognosis.
Okay, all right. Sure. So let's do the discussion part. Okay, all right. So Sarika, how was it? I know that only the issue was instead of like making this girl, okay, so by mistake it was boy actually, okay. So
Yeah, so male, I was thinking because it is X-linked dominant, no? So then I could not
yes,
think of Incontinentia Pigmenta.
I agree. Okay, all right. So how was it? How did you do?
I don't know. I think the last question, I think I don't know. Prognosis, I got stuck. I could not answer that. Rest all, I think that is hypopigmentation all over. They have hypopigmentation towards all the cutaneous things, skin, hair, nail. So everything is involved. And even these, I think the CNS and CVS was there. I'm not sure.
CNS involvement will be there, eye involvement will be there, cardiac sometimes can be there. Yes, I agree. Okay, I'm yeah happy about that. Okay, so guys, do you want to give feedback?
It was very good from Dr. Sarika. It was very she has a nice style of saying things very nicely, slowly, nice paced and good explanation.
Yes, very good. Okay.
So I think, doctor, if I'm not wrong, prognosis overall is good, but it depends on how many systems and what kind of involvement is there, isn't it? Or
Agree, I totally agree. It is very much it's a variable actually. Okay, the main issue here is like involvement of other systems like CNS, eyes, and other things, dental system, and so in yeah the temperature regulation is a big issue, dental issues and things like that. Okay, so it's very much variable, you can say. Agree. Anyone else? Mala. So you now okay, so you have to give the feedback for yourself and also for this.
Sir, now, sir, if she was girl, then why you tell me about the boy?
Sorry.
If she was the
No,
girl,
no, no,
then
that's
why?
okay. So that's why that was by mistake. It has happened actually.
Okay, no
Okay.
worries, sir.
But why did you tell the different answers?
Yeah, because sir, the marks were like the hyperpigmented there was, but the on the extensive surfaces and the age was also favoring. So I think about it, but many differentials in my mind at daytime. I tell you about like NAI, like in everything, like malignancy when I reach it till this point.
I NI will have like a typical hyperpigmented skin lesions, like
Yeah,
like
sir.
this
Yes, sir.
typical on the lineup, like in what is that, Blasco?
Yes.
But it should follow the particular pattern, like swirl, whirl. What is say? Swirlet or holes, kind of holes of the
Whirls.
holes, yeah, swirl pattern or holes pattern, yeah. Why did you, why
I
did
was
you?
confused in between because they were looking hyperpigmented and I was saying
Hmm.
hypopigmented, but
Yes,
sometimes they say, so that was a confusion.
sometimes can be there. Okay, so but mostly it is
Yes.
hyperpigmented. But in case of hypomelanosis of that is typically it is hypopigmented lesions. Okay,
And basically the normal skin in between looks like the patches. So we might think that it is a hyperpigmented, but actually they are hypopigmented that way.
yeah, it is there is hyperpigmentation definitely, Tony. There is hyperpigmented skin lesions. Okay, it is it's brownish hyperpigmented, soles or holes or whatever you can say. Yeah, along the line of the Blasco. Okay, all right. So anyone else? Any other differential diagnosis? It's basically is a type. It's a type of ectodermal dysplasia, guys. Yeah. So I'll show you the video again. Okay. And what is the treatment, guys? Treatment?
So treatment is
It's
supportive. So
supportive.
whatever
Yeah.
whatever complications you may find.
Yeah. So basically, the management, you can say, is a multidisciplinary team-based approach. Okay, so my team members, you have to say, so involve GP, community pediatrician, dermatologist. Okay, ophthalmologist is very, very important here. So, and also the might require neurologist also. So that's important. It's supportive management basically. Temperature regulation is very, very important. Okay, in summer and cold season, it's difficult for them to maintain the body temperature. So either risk of hyperthermia or hypothermia will be there. So and dental issues and other neurological issues, neurological deficit, seizures, you know. Um, they might develop. Yeah. And eye issues, squint, cataract, um, retinal issues, pigmentation issues, so vision issues. So that's why very early you need to get the ophthalmologist to have a look. That's very, very important. Okay, in this case. And dental evaluation is important for the dental pits, dental hypoplasia, and those things. Yeah. So yeah, cardiac issues usually less likely, but there is a possibility that.
Yeah, cardiac are mainly in the other one. The hypomelanotic, they will have CNS, cardiac, and the skin.
Yes, yes. So ectodermal structures would be affected, like skin, hair, sweat glands, nails. So CNS, eyes, those things, okay, will be affected. And prognosis actually, so it depends upon other associated comorbid conditions, and so it is variable, you can say. I'll show you the video again. Okay. I change the sex, okay, guys. So even though, like, sometimes it's maybe, suppose if that is the case, like, red herring, then still you have to be, based on your findings, okay, you have to be firm with your, your clinical. So you can see this folds of hyperpigmented skin lesions, like this. I'll run the video so you can see. Limb length discrepancy, I'm not sure about it actually. Okay, because just
Actually,
child was.
when the baby was standing, I could feel that right side. Here is tiptoeing. So I thought that the left one is short and this is a bit longer. I don't know.
No, he's just trying to show the things to you.
Okay.
See, sorry.
Okay.
Yeah. Okay. Limb length discrepancy are like asymmetry you might expect in the exam. Okay, you might see in case of neurocutaneous syndromes and these things. Okay.
So
So other
what is
differential.
this in this video? Like he has pen, that's why he's doing that. So what?
No,
I
he's
didn't get
trying to
this.
show this. Okay, he's keeping tiptoeing actually. That's why.
Okay, okay, okay. Just only one side.
Yeah, it is on one side only.
Okay.
Yeah. So other differential diagnosis, okay, you can just quote other, like maybe viral infections, staph, strepto, or whatever, like so but it doesn't look like the hyperpigmented lesions like this. So, sometimes warts and cutaneous hypermelanosis. Okay, you can do the DD. Then hypomelanoma peto also is one of the DD for this condition. Then yeah. So, but thing is that depending upon the age, okay, the skin lesions also vary. So, earlier the child comes to you, you might get some blistering lesions, varicose lesions, which you might get. So later they might, they will change, they will become hyperpigmented, atrophic, changes might be, might be seen. So they evolve over a period of time actually as a child grows. Okay. So there are phases actually, 2, 3 phases are there actually. Go through the theory behind this condition. All right. So what are the other X-linked dominant condition, guys? Other than this hypermelanism.
And
Hypophosphatemic
crickets.
Hypophosphatemic rickets. Hypophosphatemic rickets. Vitamin
Okay.
D resistance rickets.
Yes. Then
Rett syndrome.
Rett syndrome. Fantastic.
Yes.
Yes.
Yeah.
Then
And X-linked hypophosphatemia rickets. Yeah, this happens. And
yeah, she told that told. Hypophosphatemia rickets is done already. Okay. Then incontinentia
Rett
pigmenti.
syndrome.
Okay. Then what else? Rett syndrome. Okay. Happy. Is there any other condition? There is one renal condition also, no? Who's to read?
Airport syndrome, but it's a different, no? Also X-linked recessive, X-linked
Also,
dominant as
okay,
well.
so X-linked dominant also available, I think it's there. Okay. Even though it is autosomal recessive mostly, but X-linked dominant also it is there. Okay,
Which
so
one,
I'm
sir?
happy.
Alpert.
Airport
Alport.
syndrome, no? Different variants are there.
Yes, I agree.
Okay.
So I'm happy that Sarika brought out that the sex. Okay, so X-linked dominant usually the girls are affected. Okay, the boys won't be surviving until this age. Okay, that's very, very important. Okay, so the closest differential diagnosis is hypomelanosis P2, but however the skin lesions here like hyperpigmentation. So there you don't get the hyperpigmented skin lesions. Okay, so in case of hypomelanosis P2, you don't get like hyperpigmented skin lesions. Do you want to see that? How it looks?
Yeah.
Okay, I'll show you. Is it visible?
Yes.
So hypomelia P2, mosaicism, family history is rare, neurological association, like, you'll get mental retardation in 70% cases, seizures in 40% cases, microcephaly, 25% cases, developmental delay, deafness, visual problems, headache, and so tooth and mouth problems could be there. So you can see these lesions. This is hypopigmented, skin lesions. You can't see hyperpigmentation. This is the difference, main difference. Okay. All right. All right. So that's it about the second video station, guys. Do you have any question? No question. You can proceed further.